Hello, and welcome to the June 2022 edition of Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid. My name is Claudio Varga, and I'll be your host for today's program. The Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid, is a monthly virtual meeting open to anyone and everyone free of charge, where we share and discuss all things related to urgent care, both in California and nationally. The California Urgent Care Association is a state chapter of the National Urgent Care Association. If you are a member of UCA and located in California, then you're already a member of CALUCA. And we urge and invite you to become more involved with us. There's a lot going on, and we'd welcome your participation. For more information about CALUCA, please visit our website at www.caluca.org. We welcome your feedback and suggestions for future episodes of Urgent Care Town Hall and invite you to be a presenter yourself. Just email us at info@caluca.org. A quick reminder that the annual Western Regional Urgent Care Conference presented by CALUCA is fast approaching and will take place in the breathtakingly beautiful city of Monterey, California, over the weekend of September 17th and 18th. This will be the premier urgent care conference of the fall, and the focus is on timely urgent care topics of importance to the Western region of the U.S. CALUCA would like to encourage all California members to attend, and we'd also like to extend an invitation to all our brothers and sisters from all Western states to come join us. If you're from Oregon, Washington, Nevada, Arizona, Utah, New Mexico, or Hawaii, or actually any state in the country for that matter, this is your excuse to come visit Monterey and see iconic destinations like the world-famous Monterey Bay Aquarium and Cannery Row, play a once-in-a-lifetime round of golf at Pebble Beach, or maybe even take a side trip to Big Sur and Hertz Castle, which has just reopened. Bring the family and make some memories that will last a lifetime. For more details about the conference agenda, registration, and room reservations at the Hyatt Regency Monterey Hotel and Spa, please see our website at caluca.org. This event will sell out quickly, so please register and book your room today, and we'll see you in Monterey. We've got a terrific program today with a distinguished guest speaking on a fascinating topic. But first, on behalf of the board of directors and our membership, we'd like to thank and welcome Cepheid for their sponsorship of not just today's town hall, but of the entire Urgent Care Town Hall schedule for the rest of 2022. Over a decade ago, Cepheid set the standard for innovation in automated molecular diagnostics, and they've never looked back. Today, Cepheid can boast of having the largest installed base of any molecular platform and is constantly innovating and evolving its capabilities to keep pace with today's shifting healthcare landscape. The Gen Expert system has been heralded as game-changing by healthcare leaders across the globe, enabling institutions of any size, from small medical clinics to urgent care clinics to high-volume reference laboratories and hospitals, to access the speed and accuracy of molecular diagnostics. Cepheid's growing expert test menu spans multiple clinical applications, including healthcare-associated infections, sexual health, critical infectious disease, virology, and oncology. Of particular value during the COVID-19 pandemic has been their PCR Plus system, which delivers speed, accuracy, and flexibility. Please visit cepheid.com today to learn more. Our special guest today will be speaking about a very important topic that is certain to be valuable to all urgent care providers watching. Dr. Reza Ghomi, the Chief Medical Officer of BrainCheck, who was originally scheduled to present, was unexpectedly called away, and so unfortunately can't be with us today. However, our co-speaker, Mr. Philip Godwin from BrainCheck, will step in and do the honors today. Philip, welcome to the show. Please tell us about BrainCheck and your role there and why this information today is so valuable to urgent care providers.
Thanks for the introduction, Claudio. It's great to meet with you and great to speak with everybody. BrainCheck is specialized in providing neurocognitive solutions for all different types of practices across the United States. We specialize in primary care, neurology, urgent care, internal medicine, and perioperatively as well. To get into my presentation, I'm excited to share my screen with everybody, so if you can spare with me for just a second, be happy to go forward and do so.
Super, we're excited. Thanks very much for being here.
Absolutely. So in Dr. Reza's absence, I call him Dr. Reza for everyone to know. I do have some recordings of him answering some common questions that we hear in regards to urgent care with using digital cognitive testing solutions and in general with cognitive solutions in urgent care. So Claudia, thank you for the introduction, and it'll be great to introduce myself again. So I am with BrainCheck, and my main role working with BrainCheck is to advise and train physicians, administrators, and staff on how implementing digital cognitive testing can lead to increased diagnostic accuracy literacy, better patient care, and helps reach all those affected by Alzheimer's, other dementias, and other cognitive impairments overall. So just a bit of an overview of what we'll be chatting about today. First, we'll examine the current landscape of urgent care and primary care at the population level, and what this means for you and your patient visits relating to cognitive care, looking at more of the increase of patients without primary care physicians and what that means being an urgent care clinic. Next, we'll discuss why dementia and other cognitive impairments are important to assess and their comorbidities with common urgent care visit cases. And we'll also explore risk factors associated with cognitive conditions such as altered mental status, delirium, TBI, and dementia that can warrant cognitive screening. We'll really be focusing on those four main use cases. And additionally, we'll explore urgent care outcomes with improved screening through digital tools. So before we get started, I first wanted to add some insight from Dr. Reza Ghomi about the landscape of medicine and why all physicians, regardless of specialty, should strive to provide a comprehensive level of care at all levels, including cognitive.
Why should medical providers care about cognitive testing and urgent care? I think in urgent care, part of the beauty of it is we get to focus on the kind of more urgent problem right in front of us, and put a plan in place, hopefully provide a quick solution and move on. I think healthcare, the direction we're going, especially with payment models shifting now drastically, within these next few years, there's going to be even more shifting where patients and payers, right, are incentivizing our performance based on how patients are actually doing. And so the pressure or the incentive is really being removed from simply providing an intervention in one time point, taken out of context of that patient's life and that patient's functioning across the spectrum. So it behooves us as medical providers to think about the patient's entire life, even when they come in for an urgent care visit, and say, you know what, right now you're feeling a little sick. How is this off of your baseline, and is your baseline where it should be? I look at myself as a specialist as having a responsibility in a primary care sense. I think we look at primary care docs who really carry the bulk of, medicine, but we should all be thinking about patients. I feel very strongly about this in terms of their big picture, what they want in their life goals, what they want to be doing, and are they able to do that? So when a patient comes to me, I'm not going to just simply say, well, your lab results are within range, great, thank you, and go back to your primary care. I will always ask with every patient, even as a specialist, not just, oh, well, is your cognition, is your cognitive test, in the right range? It's, how are you doing? Are you able to still do your work? Are you still able to cook the meals you love? Are you still able to do your finances? Are you still able to get around town and navigate? Are you able to watch your kids or your grandkids? Those are the things that matter. And luckily, I'm actually very happy to see that payment models are moving towards incentivizing those things. And so as that happens, urgent care is coming into the mix here. And so I think it really matters to care about cognitive testing, because that gives us a really nice proxy for how patients doing. If their cognition's not well, they're not going to be doing well. If we catch it ahead of time and really early in the process, the impact is enormous. We've done enough studies now to know this needs to be implemented. We don't really need to be discussing it, more at this point. We know for a fact that if we detect someone's cognitive change a year or two earlier, the impact on their life is tremendous. Not just on the healthcare system. We don't just save tens of thousands of dollars, which we do, but think about that patient not getting fired from their job and, in a dramatic fashion, not having caregiver burnout, their family members just, pushed to the brink of collapse. Think about how impactful that is. And the times, which I'm lucky enough when I do see patients and I do diagnose early, I've never had a situation where they say, man, I regret that, or that didn't go well. It's always, wow, thank you so much. This is amazing, the impact it had. They were able to drive longer, stay at work longer, stay at home longer, avoid, residential living. The positives are really, it's a pretty long list. And so I think zooming out, definitely zoom in, you take care of what's ahead of you in terms of the urgency. Okay, you've got an infection, we need to treat that. But then I need to know, well, a week later, 2 weeks later, is your altered mental status better? did I just see you? Are you, a lot of people use urgent care as their primary care, right? A lot of people, we know, a lot of our patients are return, customers. They keep coming back. They're not getting they don't have a consistent primary care doc. So for all these reasons, caring about cognitive testing in the urgent care setting is, I think, critical. And I think as healthcare unifies and incentivizes, how a patient's doing and what we're spending, it'll become even more important. And so getting on the kind of track to doing cognitive testing and working, building it into your workflows early will only be an advantage, I think, as time goes on.
So in reference to what Dr. Ghomi was mentioning in his little speech right there, I'll just have my screen back. So let's take a look at the current landscape right now when it comes to primary care. So this table that we're looking at right now represents adults that did not have one or more individuals they thought of as a personal doctor or healthcare provider. These percentages are weighted to reflect population characteristics, and these numbers are specifically for the state of California. So as we can see, all adults, almost a quarter of all Californians, do not currently have a primary care physician. And if we look more closely, minority populations are more at risk, specifically looking at the Hispanic community with the highest percentage of 31.8%. Now, if we narrow this focus down into a deeper scope of representing the percentage of adults in California reporting they have not been to a primary care physician in the last 12 months, purely because of the cost associated with having that level of care provided to them. And as we can see here, the percentages in the demographic relationship are a bit more consistent, but with Hispanics, we also see almost double compared to other demographics. And there's already hesitancy to see physicians due to cost, which sends patients like these in emergencies when they have to go see a physician into your door, being in an urgent care clinic. And these percentages are only increasing with time. A study published in the Journal of the American Medical Association collected over 24,000 data points, 24,537 to be exact, over about a decade. And they looked at the percentage of people with a primary care physician. They stratified it by age group, so decades, 20s, 30s, 40s, et cetera, all the way up to 80s and 90s. And what the results were of this long-term study was they found that every single decade of age, except for those in their 80s, showed a decrease in having a primary care doctor. The statistically significant ages were in the 30s, 40s, and 50s. So in that mid-adult to early elderly ages. So when looking at the correlation between access to primary care and comorbidities experienced across all age groups, there was a 9% increase in comorbidities over the study time period. So what does this mean? Looking at these numbers, it's clear that there's an increase in comorbidities between 2002 and 2015. There are other associated comorbidities like obesity, heart failure, things like heart disease, but also there's an increased cost of care as a result of this, which causes patients and people in their 20s, 30s, 40s, and 50s to not want to go see a primary care physician purely because of cost. And as we can see, this is just a snowball effect. There's an increased cost for patients down the road, and in total, an increased strain on the healthcare system overall. And this causes stressors for payers, for providers like all of you, and especially for the patients as well. So why are people ditching having a consistent primary care physician? Well, this study referenced a few reasons as to why. First is choosing interactions that happen more sporadically rather than having the continuity of having an annual checkup every single year, purely due to cost reasons. And additionally, with the cost reasons among uninsured Americans, this also prevents individuals from seeking or accessing primary care. Third is the shortages in the availability of primary care. This causes barriers to people even with insurance. So this causes an increase in time to see a physician. This causes less time spent with each patient. And this also definitely impacts younger populations more. And with stigmas relating to primary care, not adapting to modern times with new technologies to help identify different types of conditions and new revolutionary treatments, this could also be an impact as to why individuals are no longer or less likely going to a primary care physician on a regular basis. So future projections also look like there will be a decrease in physicians overall across the board within the United States, both with specialty providers and with primary care physicians. While there is a bit of a range in the projection of expected losses, it still is not in a very positive light by the year of 2030. And inversely to that, the US population is looking to grow by 12% by 2030. And with those Medicare aged 65 and older having an increase in comorbidities, having an increase in ages, 55% for those 65 and up, and those 73%, those 75 and up, respectively. So what does this mean for urgent care? Well, I think we saw a glimpse of what this might mean for urgent care just through COVID over the past couple of years with increased patient flow, staffing issues across the board. I mean, the number of times that I personally hear a physician mention that they're short-staffed infinitely outnumber the times I hear the opposite of clinics being properly staffed nowadays. The time spent per patient has unfortunately continuously decreased over time due to the increase of patient flow into these clinics. And as a result, wait times are longer with the higher populations and with the increase of comorbidities due to various epidemics going on across the country. Now, what is so urgent about cognitive issues? If you all are already seeing cases that come in on a daily basis that require immediate attention, acute reasons like traumatic brain injuries, like urinary tract infections, why worry about something more degenerative that happens slower over time, like dementia?
When I think about urgent care and the type of work we do in that setting, why is cognitive testing important? Right off the bat, I think of my older patients that tend to come in for various reasons, but the one common thread there is altered mental status or delirium, which is very common as you get older, unfortunately, especially with some of the presentations that would bring you to urgent care. So for example, with infection, common ones are urinary tract infection or upper or lower respiratory tract infections. Those will often present in an older population with altered mental status, may not present with many other positive review of symptoms, but the altered mental status will be the trigger to look for a medical cause. That's an area of a huge intervention, where in the end, it ends up being life-saving with an intervention, an appropriate intervention. So capturing that altered mental status, it may be subtle at first. There may be some cognitive changes that are just sort of sudden, but not so prominent that the family or caregivers are, concerned to a high degree. But that could really be the start of a major infection. And so using some kind of cognitive testing within that environment can be very helpful. Other reasons that people come in for urgent care visits that have to do with altered mental status or delirium, very commonly also drug toxicity, not only drugs like alcohol or other, illicit drugs, very common, but really iatrogenic reasons, right? I mean, especially with the older population, they tend to be on quite a few prescribed medications, and there's a lot of side effects. We think of the Beers criteria and the long list of medications we try to avoid in patients as they get older, especially if they have signs of cognitive decline already. So things like anticholinergic medications, so common, right? We try to treat our patients' bladder issues, we give them a lot of anticholinergics. Well, that might lead to cognitive decline or cognitive changes in falling and so forth. So there's lots of medications, pain medications, and commonly, we talk about a lot, very, very common to have altered mental status. Also, when you get older, with urgent care, in the urgent care environment, we see electrolyte imbalances, right? People get dehydrated. They might be hypocalcemic or natremic for various reasons. Some of them may require further follow-up, and referral to specialty care, but sometimes it's a matter of being just dehydrated. Those will also result in altered mental status. And if it's for a lot of these folks, if it's a chronic issue and it's sort of subtle, they might have this sort of cognitive changes that would be picked up with testing, but not necessarily detected on a routine visit. And so that testing can kind of go a long way to help detect those changes and then really nail down the medical driver of those changes. And the nice thing is these are reversible causes of cognitive decline. Again, any other reason, so chronic medical conditions, congestive heart failures, or people with chronic respiratory conditions, COPD, those all can cause chronic cognitive changes. And the cognitive status or performance on a test may help us actually titrate treatment appropriately rather than purely looking at the end organ, performance, because maybe the kidney's performing within range that's considered acceptable, but maybe the patient's functioning is not that great yet. Maybe they're not really that clear-headed. Maybe they have brain fog. Well, we want to probably titrate according to how they're feeling and performing rather than, just the end result on the lab. I think in urgent care, in my experience, seen some, TBIs if they're mild, other reasons for, presentation that would affect their memory. TBI is really common to ignore, unintentionally ignore memory change, because often we're dealing with more acute, issues with it. So someone might actually have like a cut or a bleed, they may need stitches, or, they they're horribly dizzy, they're nauseous, they're vomiting, things like that. But, in the mild realm, people often have some, pretty significant or impactful cognitive changes, and we don't tend to capture that up front. But up front is where you have the biggest chance of helping them recover long term. I most often see patients a year or two even after their MTBI or TBI, and at that point, it's a lot harder to help them. So I kind of wish that cognitive testing was much more universal upfront at the point of urgent care or emergent care where the TBI happens, and then following closely thereafter. That would go a long way in terms of preventing long-term cognitive impairment.
Now at this point, let's briefly walk through some cognitive issues that are correlated with common urgent care visits. Off the bat, altered mental status is going to be one of the more general terms I've seen used as a diagnosis, but it's life-saving if identified. Altered mental status can usually be the root cause of urgent care visits, alluding to other issues in a patient's home life. Questions arising: are they living alone? Do they have family members with them to be able to keep track of them as some sort of caregiver? What does their medication look like? Are they taking anything that should be altered, depending on your opinion as a physician? Identifying altered mental status can help prevent readmissions and treat the root cause of more common visits, things like UTIs and upper or lower respiratory tract infections. Additionally, as Dr. Reza Ghomi mentioned, drug toxicity with anticholinergics and pain medications, as well as electrolyte imbalances. These are correlated, so one can cause the other, which is why it's really important and imperative to test for altered mental status when you see these types of cases in your clinics every single day. Some potential risk factors for altered mental status include patients being elderly over the age of 55, prior cognitive impairment diagnosed, things like dementia or Alzheimer's, underlying chronic conditions or diseases, or having a systemic infection. Personally, what I've seen is if a physician is aware of any of these underlying conditions, regardless of the reason for visit, they'll always do a brief mental assessment of that patient. So the correlation of altered mental status is shown heavily within the elderly population, as expected, with comorbidities and other cognitive impairments being present as well. Things like alterations in consciousness, delirium, and cognitive impairment without delirium. These all have pretty heavy percentage of relationships with altered mental status. From an article in the Journal of Urgent Care Medicine, there seems to be, and there's a recommendation for a full physical recommendation being completed, as well as a neurological examination while deciding if a patient with altered mental status should go to the emergency department. This includes looking at their general appearance, testing their vital signs, hydration status, evidence of any physical trauma that could be present, and, as I said, neurological signs. This exam should be done even if they are being transported to an emergency department. But there's a couple of aspects that come into play when it comes to the certain assessments to complete. So off the bat, just a couple of tests that are fairly widely accepted within medicine and are fairly traditional. The MoCA, Montreal Cognitive Assessment, and the Mini Mental Status Exam, MMSE for short. The MoCA is a bit of a more in-depth assessment compared to the MMSE. It is fairly credible. There are quite a few notable studies done showing the efficacy of the MOCA. But on the back end, it's fairly administrator dependent, and working in an urgent care setting can be rather fast-paced at times. And your time is valuable as the physician. So someone who's properly trained is recommended to give this assessment, whether it be a physician or someone like a nurse. And another side of a con when it comes to your time being valuable, when it comes to the reimbursement required or coming back from the MOCA, it's fairly inconsistent. The range can be from $20 to $80 per test completed. Now, speaking to the MMSE in specific, it is also a traditional test, and it's faster than the MOCA. It can take just a couple of minutes to complete. However, it does not get nearly as narrow of a scope or as specific of a diagnosis that the MOCA can bring. And it's fairly subjective. It's administrator dependent. And this isn't to say that physicians aren't trained in the MMSE. It's just to say that when it comes to the administrator of the test, results can vary based on who administers it. It is also pretty poor for subtle changes. Things like altered mental status can be a subtle change in someone's health. So that's something to take into account when to use an assessment like this. And what I've seen when it comes to reimbursement with the MMSE is it's fairly negligible when it comes to billing codes. Now, let's focus on traumatic brain injury. These are probably the first thought of what comes to mind when I speak with urgent care clinics about their cognitive testing. What's interesting is typically TBIs are referred to emergency departments more at a liberal rate, so more common than one would think. And this isn't a horrible problem since the patient's health is the top priority, but there was a study done, also cited in the Journal of Urgent Care Medicine in 2018. It tracked over 17,000 emergency department visits after visiting urgent care with a traumatic brain injury that's been identified by the urgent care physician. They then tracked the number of patients that were referred to the emergency department and the number that suffered any results on a CT scan showing substantial damage to the brain as a result of that referral. The results looking, though, it seems that 843 of the 17,000 were referred to the emergency department, so just under 5%, and only 4 of those 843 actually had positive results on the CT scan. And what does this mean? So, as the study says, the results suggest that urgent care clinicians can rely on their clinical evaluation in making decisions regarding the need for higher level of care or brain imaging. And it then recommends a solid MTBI examination. Thorough history required, neurological and physical exam, subcortical evaluation, and neurocognitive testing can be used in bringing all of these decisions together to make decisions for the patient and their care moving forward. And it's not uncommon that I hear a physician with certain concerns testing something serious like a TBI within pen and paper tests. And that's because these tests are primarily subjective. Sometimes physicians would like to have some more objectivity to their assessments. And that's where digital testing has come to the market within the last decade to help out. So just some examples of some digital tests, BrainCheck, of course, and another test is called Impact, which specializes within concussion testing. Some pros with these digital tests: they're fast, they're easy to administer, they are fairly independent as well. Typically, your staff member, maybe an MA or a technician, could administer one of these assessments, while you, the physician, can be focusing on other patients, particularly with maybe another acute situation going on. These tests also have higher sensitivity than in pen and paper tests and are more objective. They're able to detect some more specific signs of different types of cognitive impairment, in this case, specifically TBI, than somebody with a pen and paper test can. And this was just shown at a population level through several studies. Paper tests, they are fairly traditional. They're generally timey. But some of the cons of paper tests can be that they're too general, too subjective, as we mentioned before with the MOCA and the MMSE, and they're tough to scale for busy practices. Now, something I forgot to mention in reference to digital tests is some of the cons that could come up. So with traumatic brain injuries, one of the recommendations that I've heard when I've personally had a concussion and working with physicians is to avoid looking at screens for long periods of time. So when considering a digital test to use that can be more effective and better to read and to find these types of signs of TBI, it's important to take into account the time taken. So tests ranging from 10 to 20 minutes would be most beneficial for the patient from what I've seen working with physicians. Also, testing companies can be different. So it's important to do your due diligence when looking at a solution for your practice. That way you can then inform yourselves as to what best practices you want to bring to your patients and decide what you think would be the best tool to help your patients improve their way of life. going into delirium or diving into delirium, as one would say, there are quite a few comorbidities typically associated with this condition. These range from altered mental status, as stated previously, memory deficiencies, medication usages, sleep deprivation, pain, and sensory impairment. In the figure to the right, we actually see different characteristics between the domains associated with delirium and dementia, and what differences the two in making, and what differences to make between the two when it comes to your clinical decision making. Just a couple to make notes of. One, with attention, we can see that delirium and dementia are both different, with delirium being more disordered, dementia, the attention being more in the normal range. And there are some tests available that can identify that for you. However, I haven't found any digital tests specifically created to only address delirium compared to something like a TBI. However, there are some paper tests widely available. The confusion assessment method, or the CAM, or the 4AT, the 4 assessment test. The pros of the CAM is it's traditional, it's fairly credible, and it's universal. It's cited in numerous studies, and it's been used throughout healthcare for quite some time. The cons, just like previous paper tests we've chatted about, fairly administrator dependent. It is kind of time consuming. It takes about 10 to 15 minutes to complete. So while it's not in the 20 to 30 minute range, as some tests like the MOCA can take, if a patient is severely impaired, it does take about 10 to 15 minutes to do. So while I mentioned there are currently no digital tests available specifically for delirium, most digital tests that qualify under neuropsychological testing, which is what a lot of these digital testing companies are able to do, a lot like BrainCheck, through the CPT codes 96138 and 96132, these can aid in diagnosing delirium, specifically through that domain of attention that I just mentioned a minute ago. But what's really critically important with delirium is identifying it within the first few hours of assessment. It is very important to do so to prevent any sort of long-term negative changes. Speaking to dementia, this is what BrainCheck specializes in with dementia and Alzheimer's diagnoses. And that's because dementia is currently a large epidemic within the United States. Over 11%, or sorry, 10.7% of Medicare age patients, people suffer from Alzheimer's or dementia, with only 4% of them actually being diagnosed. So that's about over a 60% rate, or 60% gap of care for those who actually have dementia or Alzheimer's that are going undiagnosed currently within the United States. This causes an insurmountable cost to the healthcare setting. And not only that, but those with dementia have a massive chance of walking through your doors, especially because of the decrease in primary care physicians across the United States, the increase of individuals without having a primary care doctor across the United States, and with the prevalence of dementia actually developing within the 30s to 40s, we're starting to see that it's coming more and more in what's called a silver tsunami. Just a couple more statistics on with the comorbidities relating to dementia. Is there's a double chance of having a UTI if you're already diagnosed with dementia. So that is clearly a good indication for testing someone either cognitively or the other way if there's any sort of condition there. Additionally, depression and anxiety, the largest comorbidity with dementia and Alzheimer's is also having depression and anxiety. These typically go hand in hand. Sometimes depression and anxiety in an elderly patient can cause dementia-like symptoms, which is why it's important to address it and identify it early on. That way you can make changes in any sort of lifestyle changes through care planning or their diet to improve any sort of negative conditions. Next, drug and alcohol abuse. There's a large correlation between drug and alcohol abuse and dementia diagnosis and dementia development in the human brain. Medication interferences, things like SSRIs can cause dementia-like symptoms. This is where tracking a patient's performance on an assessment can be beneficial. With pen and paper tests, it can be a bit difficult to do that just with the way they're built and tracking numbers within your EMR. But digital tests do offer a good solution that we'll be able to go through in just a few minutes. Next is psychiatric disorders. When it comes to those with schizophrenia, there's a large correlation with schizophrenia and dementia, as well as other degenerative disorders like ALS or MS. This is, of course, common within the elderly population, things like depression, hopelessness, and suicidality. These should always be tested if a patient comes through your doors with these types of concerns. When it comes to the cost to the healthcare system that dementia and Alzheimer's is bringing right now, it's quite substantial. The figure on the right represents the total cost of care of those with dementia versus without dementia for common and the most common cases of senior patients. Things like coronary artery disease, congestive heart failure, stroke, and cancer have a substantial increase in the cost of care when someone is diagnosed with dementia. So it's extremely imperative, as being at the point of care, being an urgent care physician, to address that immediately, to be able to help the patients not only identify issues as soon as possible, but to help the patient save money too down the road. Because if they're unaware of any sort of cognitive impairment, they're not going to be able to see the right specialists who could then maybe even improve their value or their quality of life immediately, and improve the way that they're currently living without having to add any extra costs to their life on top of the emotional burden of this to someone in their family. So speaking to some testing methods for dementia and Alzheimer's, I know we've seen this slide previously for altered mental status. These still, the MoCA and the MMSE, are fairly useful in getting a general diagnosis of dementia or Alzheimer's. Same pros and cons still apply. Both are fairly administrator dependent. The MoCA can take some time, between 10 and actually 20 minutes, I hear, in the upwards of 30 minutes for someone that's already fairly impaired, mild to moderate. When it comes to the MMSC, same still applies as well, with the reimbursement being negligible. So when you think about your time being valuable as a physician, it sometimes, unfortunately, doesn't incentivize much when it comes to wanting to provide a high level of care and still help identify issues like dementia in your patients, when your time is very valuable too. So if you're running a small business or an independent practice, to help yourself stay above water as well. Other paper tests that are common that I hear from physicians that I work with are the SLUMS test and the mini-cog assessment. To speak to the SLUMS, it's very, very common for its brevity. It has a fairly good sensitivity for mild cognitive impairment, and it's more effective for the for MCI or mild cognitive impairment than the mini mental status exam. The cons with the SLUMS test, however, is it's fairly population dependent, because there are some concepts on this assessment due to someone's social or cultural background may not understand when doing this test. So I would take that into mind when it comes to administering this assessment if choosing to do so. It also has a lack of research regarding psychometric properties. The mini-cog assessment is common during an annual wellness exam, which happens within primary care settings and sometimes in urgent care. When it comes to the pros, it has the fastest examination time. It takes between 1.5 to 3 minutes to complete. And there's a clock drawing test, which has been shown some success in terms of identifying cognitive impairment. The scoring is fairly simple. While it's a pro, it can also be a con, because identifying cognitive impairment, especially with something like dementia, that is more of a long-term snowball effect type of degenerative disease, can be tough to identify with something like an MMSC, even though it's very general. It's also has a little bit less information collected than a test like the SLUMS or the MoCA. So that's why the mini-cog is typically used in conjunction with a wellness check while a physician is identifying other types of conditions going on potentially with the patient. When it comes to digital neurological examinations for dementia, this is where the market is also very well saturated, similarly to traumatic brain injury. There are numerous types of testing companies that are available right now, each specifying different types of domains and wanting to provide the highest level of care for patients across the country. Each different company has different applications or modalities used. Some use EEGs, some use computers, some use touch screens like an iPad. Some are primarily on their own device that they've made within their own organization. And this is something that's extremely important when considering to use a certain company. Is in my clinic, do I have one room that I want to completely designate to cognitive testing only, or would I rather have something more mobile that we can shift around and make sure to leverage any sort of room that's available with how my clinic may be running, if it's fast or slow? Is this test going to be supportive from a customer support perspective? Am I going to be able to rely on this company to help answer questions in a timely manner if there's an issue going on with the software or hardware, whichever it is? And thirdly, what's the cost to my clinic? Is this going to be something that I will have to take on a severe financial burden? Or is this going to be something that will be a very small financial investment compared to the outcomes for my patients and for my clinic as well? And again, when identifying and when considering different reasons to improve your urgent care outcomes with digital testing. The time is especially important. Some cognitive testing solutions available are 45 minutes to an hour and a half in length. I can't speak for every urgent care clinic, of course, but with generally speaking, your time is one of the most important things being a physician. So I would look to see about a 15-minute test when it comes to finding a digital solution. That way you can maintain your patient visit times within a current window and be able to provide a high level of care in that. Next, trustworthy. It's really important to have something that's registered with the FDA. That way you can trust the results that are coming in. It's already passed clearance with the United States government, and you won't need to worry about any sort of credibility issues down the line. HIPAA compliant is, of course, a requirement when creating a piece of healthcare technology, but it's always important to look into what type of HIPAA compliance does this have with my certain device? Do I need to use a different web browser when administering this test? What type of applications can I administer this on? Does this work on Windows or PC? It really depends on what type of application you have with digital testing. Next, notable research. A lot of these companies are fairly new. Within the last 10 years or so. And this is thanks to modern technology and touchscreens, to be honest with you. But with that, it's important to have credibility to back the assumptions made by some of these digital testing companies. Some will decide to do all of the research before going to market, and that can help address any sort of concerns from a physician comparatively to using a test like the MOCA. While it does have the cons of test administration and the time involved, the pros are it's been cited quite extensively within American healthcare. And last, CMS guidelines. When it comes to hitting the required domains for something like reimbursement, or even to help you make a decision as a clinician and to prevent being audited, you want to make sure that the digital test you're considering does qualify under the required domains as put by the Center for Medicare and Medicaid Services. Ease of use is especially important, especially when looking at a digital test to use. Since they do typically cost more than a pen and paper assessment, it's important to value your time and to value different aspects of your practice to lay or to change the layout of what is important for your practice. Because if you can shave off some visit time for your patient by administering a test through an MA or a technician, rather than having the patient wait an extra 20 to 30 minutes for you to sit down and do a pen and paper test with them, the outcomes from that stratified in over time is going to be very significant for your clinic. Next is easy to interpret. Some digital testing companies really focus on the aesthetic of how a report is going to be presented to a physician or provider. Others care about providing the bulk data more for research purposes. It's really important to investigate and look into each company because they each have different missions in mind, whether it be for more research purposes or neuropsychological testing with a neuropsychiatrist, which can take 8 to 10 hours in length, or for a quick test that can take 5 to 20 minutes and provide you with an aesthetic report that you're able to make clinical decisions in a quick time. And lastly, it needs to be worth the investment as well. As I've mentioned, that digital cognitive testing does cost more than pen and paper testing. However, companies have really focused a lot on making their tests affordable for you, making it easy to bill based off of the number of tests that you run or the type of patients that you see. It really just depends on the company how their cost structure is put together. Next is reimbursable. Most cognitive tests do reimburse more than a test like the MOCA or the MMSC. As mentioned, the MOCA will get between $20 to $80 per test. As we'll see in just a few minutes, we actually have noticed an increase in reimbursement, especially through Medicare, if a certain digital test does hit requirements put in by Medicare. And if the investment improves your outcomes as a clinic, as I mentioned with the ease of use, then it's clearly worth the investment. One of my favorite things working with physicians is seeing them excited to use us, BrainCheck in specific, because we are able to decrease the amount of time a patient is actually in their clinic, but still provide more in a deeper level of care and analysis of their cognition during a regular visit. So here's an example of a BrainCheck report, just to show what these digital tests may be reporting when it comes to the domains. Another aspect of digital testing I didn't cover was objectivity, something like comparing with a normative database. That's very important with making a decision. To speak to BrainCheck in specific, all of our test scores are based on a normative database that has been previously put together based off of their age group. So a 70-year-old male is only going to be compared with other 70-year-old males in their age group. So 20-year-olds, 30-year-olds, and 40-year-olds, those seen in that at-risk population group without having a primary care physician will actually be scored with a different population. The aesthetic is very important for brain check in specific, and you can also measure different aspects of cognition. As we stated, things like delirium and altered mental status, having some comorbidities, also with dementia and depression and anxiety, it's important for these companies to be able to portray and collect data to help physicians like you make the decisions that you need for a patient's cognition. Some other domains that a brain check report covers are things like attention, mental flexibility, executive function, and memory. And with our tests, we're able to identify things like dementia and Alzheimer's, things like medication management, overuse of SSRIs or something like birth control, things like anxiety and depression, traumatic brain injuries, or other use cases as well, things like multiple sclerosis to be specific, and perioperatively too. When it comes to the efficacy of diagnostic testing with digital solutions, we also ran a study on the specificity of diagnosis through digital testing compared to a test like the MOCA. And what we found after running this case study was a general increase and a statistically significant increase in the specific diagnosis provided for doing a solution like brain check. And with the management planning, you're also able to provide a deeper level of care with having a digital test available, because it lowers the stressors of you as a physician when it comes to administering the test and making the decisions, because you're able to focus more on the patient instead of the task at hand. So when it comes to digital testing solutions and improving urgent care outcomes, there's 4 main points that digital testing has really done to improve the healthcare system in this regard. First, they're able to provide rich objective data to support clinical decisions and patient stratification. This improves the diagnostic confidence and brings a higher quality of care to patients, hopefully alleviating any sort of stigmas with primary care being a bit behind the ball, as well as urgent care being behind the ball with their testing modalities. The second is when it comes to time, your administration by MAs or technicians, rather than a physician, is another big bonus when it comes to using a digital test, because it takes the time out of your hand and puts it into someone else's who can be useful in your clinic to help you focus on other patients that might need it, saving you time and saving you money as well with the labor costs. The third is allowing allowing rigorous documentation to support reimbursement. This helps as well when it comes to submitting claims to Medicare or other insurance companies. A lot of these cognitive testing companies will handle the actual documentation information for you, while you will still need to bill for the services through most of these companies. They'll be able to give you the reasons why a certain diagnosis might be needed as a diagnostic tool to help you and your office staff from spending a lot of time in your EMR. And the fourth is clearly modern improvements, making it easier and more convenient for patients to take tests, lowering any sort of stress when coming in to take a psychological assessment or a neurological assessment as well. I've personally seen patients smile while playing games on their iPad. So why not, with a cognitive test, do the same thing and make it easier for them too. So one last bit from Dr. Ghomi on cognitive testing in urgent care.
Also keep in mind that of the 5 to 7 million Americans right now living with Alzheimer's disease that we know statistically is true, less than half have a diagnosis. And families will tell you over and over again that, those initial touch points, whether it was early on, a little bit of altered mental status after a procedure, after an illness, after one of the many reasons we discussed earlier, those are all opportunities to catch the cognitive impairment or the cognitive decline earlier in the course. When patients are coming to me or getting diagnosed, if they get diagnosed later, which again is the minority of the time, that's after a long road. So generally years, cognitive decline is going on for years, and then it's finally something's collapsing, a care structure is collapsing, and move a transition, which really flares some kind of symptom or functional impairment, and then they're moving out or going into residential living, and so that's usually kind of what we're seeing. But in urgent care setting, we're seeing patients early on in situations where we have an opportunity to potentially detect early. So that's for me, that's a huge incentive to think about cognitive testing in these care settings, because these are the settings where we're able to capture those patients that are coming in early. Also keep in mind that
And just to speak, when it comes to capturing cognitive impairment and your time as a physician, here are some CPT codes to look into when administering neuropsychological testing. These are 96138 and 96132, can be billed with a general office visit, like 99214, for example. This way, you're able to add these services to your time and still be able to keep your business up and running within your urgent care setting. So I thank you all for the time. I really appreciate it. Again, my name is Philip Godwin, and I am with a digital testing company called BrainCheck. For those of you interested in reaching out, there's a QR code on the screen. Feel free, hold your phone up, and my email is available for you if you have any additional questions after the presentation is completed. Claudia, thank you for the time.
Awesome job, Philip. Awesome job. That was so much information. Yeah, that was, I mean, not to share too much, but I'm sharing, I'm experiencing some of these things with a family member, an elderly family member. And it's tough, it's trying, and you never really are sure what exactly is going on and to what extent. And it's hard to get real good, solid advice. So I think that this will resound with people, clinicians, practitioners that on a daily basis are seeing all kinds of people coming through the door, and you want to be able to help them. And I think this is really, really a very, very helpful subject. I just had a quick question for you. So what does this look like, your product, your service coming into a clinic? I mean, what does that process look like? I mean, what's involved in saying, I want to offer this to my patients? Just what are the main steps in implementation?
Sure. So it breaks down to 3 steps. The first step is we have a discussion or a demonstration over a live call. That way we can determine the specific use case of our solution within a physician's clinic. So this can depend on whether it being an urgent care setting or primary care or neurology. That way we're really able to specify and provide a good solution for someone who wants to make the investment in something like BrainCheck. The next step that we do is we train you on the house. Training only takes about 45 minutes for a product. I actually spoke with a clinic yesterday that was using a competitor, and it took about 10 hours of training for their entire clinic to use. So quite a bit of time investment for something like that. So one of the reasons why BrainCheck has been so successful, even through COVID, was through our ability to make something seamless and easy for providers to administer and for patients to take. Not only that, during that second step, we have our customer success team available 24/7. That way, you're able to get answers immediately when it comes to providing better care for your patients. The third step is implementing it in your clinic. So after training, we consistently check up with each clinic and their specific use case, looking at, hey, what type of patients do you think we should be testing? What are some signs or identifications we should be looking out for? How can I add a correct diagnosis code to this? What type of diagnosis code should I use? And that's what our customer support team and our onboarding team is built for, is making this solution for BrainCheck in specific as easy as possible for physicians to implement. So Claudio, it's broken down into those 3 steps, but we're clearly always in communication with our customers, being a subscription-based service.
Super. Thank you. Seems easy enough. I mean, I'm envisioning that it's not terribly complicated. There's not gigantic machinery involved or things like that. So this seems like it would be something pretty straightforward and pretty easy to implement in an urgent care. So I know that we'll be looking at this very, very closely shortly and see if we can put it to good use. So super. Thanks again, Philip, and thank Dr. Ghomi again for your participation today. It's been very, 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 very interesting. And again, I would encourage anyone looking for more information. You got an easy enough website, braincheck.com. Go over there and take a look and request. I saw there's a demo on there, and there's a wealth of information on this topic on there. So, yeah, wonderful. So thanks again, Philip. I'm going to just take over real quick here and remind people of what we got coming up here.
And Claudia, just to interject, I missed that one aspect. You mentioned application and how to actually do a test like BrainCheck. We are administered on an iPad or a computer, and we're fully compatible with telemedicine as well. So that's why we make it as easy as possible for patients to do a test like this.
Awesome. I assumed that, but I'm glad that you specified that. I figured it was you mentioned tablet many times and touch screens and things like that. So that's awesome. Well, thanks again. Really, really, really appreciate the presentation.
Thank you.
Yeah. So once again, we just wanted to remind folks that we're only a couple of months away from the Western Regional Urgent Care Conference, which is going to be in Monterey, California. We've got a great room block at the Hyatt Regency Monterey Hotel and Spa. So please, for more details on the conference agenda, registration, room reservations, please see our website at CALUCA.org. And we will see you next month for our next Urgent Care Town Hall, sponsored by Cepheid and presented by California Urgent Care Association on Thursday, July 14th, 2022, same time, 12 noon Pacific Standard Time. So once again, thanks to our guests from BrainCheck, and we wish everyone a wonderful rest of the week and a terrific month until we see you again next time. Thanks, everybody. Bye-bye.